Good morning, everyone. Good morning. Welcome. Please take your seats. We're thrilled to see the full room and to see all of you here. Welcome, everyone. My name is Ann Kurth. I'm the chair of the CUGH board, and it is my honor to kick us off here just briefly, and along with our illustrious panel. I want to start, of course, with thanks to our executive program committee and chairs, and that's Drs. Murphy, Garcia, Olapade, Wine, and of course the local organizing committee, the scientific program advisory committee, the conference management team, including the CUGH secretariat, and the staff. Do you see how much work it takes to put this conference together for you all? And then thank you. Let's have a clap. But then thank you, each of you, for coming. It takes time and energy and resources to gather like this, but we hope that it returns to you in multiple ways. This is a powerful time to be gathering to talk about global health. As a side note, this is the 10th anniversary of CUGH conferences, so it is a bit of a milestone. Over a decade ago, there were some visionary university leaders who gathered, and with support from Gates and Rockefeller and other funding, it allowed the CUGH as an organization to start. So we have these roots, including later, that we were joined as an organization by GHEC, which had been around for a number of years. And our first conference, it should be noted, was hosted by the NIH, was at the NIH. So as important as it is to look back, and these milestones are times where we think about looking back, we also crucially, of course, must look to the immediate term and the future, to where we need to go. So to truly unleash the power of universities to improve the health of people on the planet, and that, by the way, is the mandate of CUGH. That's why you're members. That's why we're here to support you as university communities, to unleash that power of what academics uniquely can do. This is part of our updated mission statement. We need to really come together. And I am proud to note that at our board retreat meeting just a few days ago, we actually invited other academic global health networks, existing global health networks from around the world, and we spoke to each other about our priorities, our challenges, and how we might synergize our work together. Because I think each of you are here because you recognize universities bring something distinctly that can contribute to improving the health of people on the planet. And now more than ever, we need to fight for our vision of that and work together across borders and ideologies. Truly, the survival of the planet depends upon it, as we saw in the recent IPCC report in October about the time frame in which we need to take serious action as a society. So our conference theme is implementation science. We know that putting what works into scale will save millions of lives right off the bat. Each of you are critical to that mission, the shared road ahead we must travel together. So I'll just urge you all to work hard these next few days, partake of all the incredible expertise gathered here. We are 1,750 people attending from 50 countries. Take advantage of that. We have so much to learn together, make friendships and colleagues and compatriots, and have fun also. Reminder that, and this was a wonderful idea from our board member and vice chair, Michelle Berry. What is today? International Women's Day, that's right. So the theme for the day is Better the Balance, Better the World. So in honor of this day, we are requesting that everybody who is speaking today, during your speech, please name a woman who's inspired you and say why. Okay, so for me, I'm just going to say generally, any woman who runs for office. And I would say also for a specific person, Dr. Natalia Kanem, she's the executive director of UNFPA. She recognizes the contribution of nurses and midwives around the world, and UNFPA, of course, is the largest provider of contraception, which directly, of course, affects access for women and girls to live their lives free of violence and lack of control of their own reproductive wishes and destinies. So she's a heroine. So be that person who runs for office, or support a woman who runs for office or a board, and for all underrepresented, underserved individuals who hold up more than half the world to make a difference. contribute to the work of universities and our partnerships, translate knowledge into impact, improve, and indeed, please help save the world at this time of planetary stress. CUGH exists because of the work you all do, so go forth, learn together these next few days to make that work even more powerful, and stay connected beyond the conference through CUGH into the next second decade. Thank you.
Good morning. I'm Rob Murphy. I'm the director for the Center for Global Health at Northwestern. I'm one of the local co-chairs of this meeting. I want to welcome you all to very balmy Chicago. I want to tell you how lucky you are that it's a balmy winter day. And actually it's going to get above freezing for the next 2 days after today, and that is like truly, truly unusual. Really welcome to Chicago. We're the three of us local co-chairs are very happy to have you all come to our beautiful city and to celebrate this 10th anniversary of CUGH, which is this year. It also happens to be the 10th year of the Center for Global Health at Northwestern. On behalf of the International Day of the Woman, I want to thank two women who actually built the center along with me starting in 2009. Carolyn Bear, who's actually in the audience, now work at the Henry Jackson Foundation. She and I started 10 years ago. We had 2 international projects. We had students all over the world. We didn't even know actually what countries they were in, and we put the whole program together, and I have to say that it's evolved into a very successful program, and we're really very proud of it. Carolyn subsequently left for CDC and is now at Henry Jackson, as I mentioned. And now my new deputy director, who actually keeps the whole program together because I'm always internationally gone, is Kate Klein, who I'm not sure she's here because, I'm sorry, I take it back. Kate is over there. Kate, this may be her last public function until she delivers her second child. So congratulations. But anyhow, we've come a long way. We're very happy to be here. We're a school that sends about 50% of the medical students on an international experience of at least 4 weeks throughout their medical career, one of the higher percentages in the country. We've got a nice Center for Global Health that has a nice portfolio of research projects. We have support from the Fogarty International Center, from the NCI, NIBIB, the Biomedical Engineering Institute, and NIAID. So we've got a nice spread and diverse portfolio with about 20 active projects right now. Many of our partners from our different countries that participate with us are here also. We have 3 universities from Nigeria, Universities of Ibadan, Lagos, and Jos. Representatives are here. And also for International Day of the Woman, I want to also recognize Shade Ogunshola, who I started working with in the old PEPFAR days, who is now the Deputy Vice Chancellor of the University of Lagos, one of the first in Nigeria in history. So congratulations, Shade. But anyway, we also have nice programs in Mali, and we're doing quite a bit of work there, and also in South Africa with Tanya Douglas, who's also here, who had been the chairman of the Biomedical Engineering Department as well, the first woman to actually run that department. So I'm surrounded by women that are very powerful and important who have helped me, and I'm very, very, very grateful. So again, this is just introductory. Welcome again to Chicago, and I hope you enjoy your stay here and the conference in general. Thank you very much.
Good morning, and welcome to Chicago. My name is Shola Olopade, and I'm a professor of medicine at the University of Chicago. And I'm the director of the international programs for the medical school. And I also serve as the clinical director of the University of Chicago Center for Global Health. Incidentally, we're also celebrating our 10th anniversary, so it looks like something unique about 10 years. What we do is very much in line with the spirit of this conference. Our center provides a unified framework for students and faculty across campus with an interest in global health and reinforces the University of Chicago's strength in fields such as the humanities, life sciences, social sciences, medicine, public policy, and more, because we don't have a School of Public Health. So we have a unique opportunity to actually do interdisciplinary work, and we enjoy that. And this interdisciplinary focus encourages innovative approaches to the numerous health challenges faced by residents in the city of Chicago and people across the world. It has been an immense pleasure to learn from the work alongside such brilliant global health scholars and leaders, Patty, Rob, Stephen, and the fantastic team at CUGH to bring you this year's program. I'm a pulmonologist and by training, and my research focuses on the relationship between environment and genetic factors as it relates to expression of asthma. So personally, I'm thrilled by the theme of this year's conference, which is Translation and Implementation for Impact in Global Health. In recent years, we've worked to expand our understanding of the impact of exposure to household air pollution on health, which today being the International Women's Day is also very special because women bear the brunt of the health consequences of exposure to household air pollution just by virtue of what they do. So I'm dedicating our work to all these wonderful women. We're very excited to feature and learn from a diverse group of multidisciplinary scholars from all over the world who are making a significant mark in their field. Through a series of interactive presentations and discussions during this conference, we hope to cover a range of topics, foster network building, and also collectively work towards developing action items for solving the world's most pressing global health issues. In this room are senior scholars, junior level professionals from multiple sectors, providing a valuable combination of experience, enthusiasm, and varied perspectives to our discussions. This year, we hope to enhance discussions by looking to lessons learned in the global space that could be implemented in certain settings, even in the United States. Thank you for your time today, and we look to a very productive and exciting program. Welcome to Chicago again.
Good morning. On behalf of the University of Illinois at Chicago, I want to welcome you to Chicago and to the 10th Annual CUGH Conference. We celebrate International Women's Day every day, and we have a number of outstanding women scientific professional leaders in our programs who I'll shout out as I go along and tell you a little bit about who we are. University UI Health, we call ourselves, is the academic health enterprise of the University of Illinois, and it encompasses 7 different colleges, including nursing and public health and medicine. We are Chicago's public research university, and we combine commitment to working with the people of the city of Chicago and all of the challenges and complexities of that with state-of-the-art scientific research and global commitment. We prepare future medical and public health and nursing and other health professional students to address health disparities and social determinants of health, whether it's in local low-resource communities or around the globe in low-income countries. So at the College of Medicine, we have lots of different engagements with LMIC countries conducting transdisciplinary research. We also train the next generation of medical students in our GMed, Global Medicine program, which has 12 medical students a year who embark on a 4-year comprehensive longitudinal curriculum, including a capstone, and many of those students go abroad, and many of their works have been published and presented, including at this meeting, so look out for them. That program is led by Dr. Stacy Chamberlain. Is Stacy here? Yo, Stacy. I can't see you. There she is, way back there. All right, Stacy. But I don't only represent the College of Medicine here today. I want to also give a shout out to the College of Nursing and School of Public Health. The College of Nursing has a global health program led by Linda McCreary. Linda? There she is. All right. Linda McCreary does an outstanding job. She, in fact, teaches a course on leadership in global health, which is a valued experience for students on the campus. And they have a really great interdisciplinary and interprofessional global health program that involves education, practice, research. They participate in international collaborations between health professionals, governments, educational institutions, and other partners that unite around the concept of health for all. And they have active collaborations in India, Malawi, Rwanda, Haiti, Indonesia, and elsewhere. Talk with Linda more about that if you're interested. And finally, we have the School of Public Health, and we have Allison Lofthouse, who's a leader of that program. Allison, I suspect you're back there. No, I don't know. Allison? Okay, well, come say hi to Allison. She's around the meeting if you can. Global health is one of their priority areas. The school offers a master's level concentration in global health that has 38 students currently enrolled. There are faculty members from all of the divisions of the School of Public Health who are doing really outstanding projects all over the world, including funded research projects. In fact, I'm going on Sunday to visit one of them in Kisumu, Kenya, led by Robert Bailey. So as you can see, we see it as a commitment across all areas of medicine to focus on global health. And I've seen over the last number of years an increasing, really strong commitment from university leadership to make this a truly global university. And we're also deeply committed to overcoming the potential silos in all of our fields and to interprofessional collaboration between medicine, public health, nursing, occupational therapy, all social work, all the other disciplines. So I look forward to an excellent meeting over the next couple of days to learn more about the innovative work that all of you are doing. Please come say hello to us if you have a chance. But also, you're in the city of Chicago. Chicago is a city of neighborhoods, a city of great blues and jazz, so I hope you go and check that out. And lastly, in terms of women, we should note the very special moment we're having in the city of Chicago, where we have 2 outstanding women mayoral candidates. So thank you very much.
Good morning, everybody. It is absolutely a delight to see all of you here today for our 10th anniversary conference. My name is Keith Martin. I'm the executive director for the consortium. These conferences would not happen without you. And I just, on behalf of all of us, I know it's an incredible sacrifice for you to come here, both in time and money. And I want to thank you for doing that, and particularly for those of you who have come from afar and have come from very warm climates to Chicago. But as was mentioned, it could be worse. And on this wonderful International Women's Day, I am also privileged to work with an extraordinary group of women, and I'd like to honor them, Dalal and Karen and Stephanie and our great intern Sarah, but also our project officers Kim, Arissa, and Marissa. Our CUGH would not work without their enduring efforts, so I honor them. And also for a colleague who, colleagues who don't receive many awards and go about their business in quiet, effective ways, I'd like to honor somebody who has been dealing in a quiet but a remarkable way to deal with the leading cause of disability in the world, mental health care, who's worked with our colleagues in low-resource settings to be able to provide access to mental health care service to those who are least privileged in our world. So I'd like to honor somebody who didn't know she was going to mention this, but Dr. Claire Payne, who actually happens to be here in the audience. Claire. We selected, colleagues, this particular title because we know that we've made great inroads in global health challenges, but we know that we have great threats before us, whether it's non-communicable diseases or the fact that we are shredding the ecosystems, the life support systems of our planet. And so we have no time to lose. So what we wanted to do is to bring you all here together to be able to convene, to learn, and importantly, to be able to establish things we can do when we leave here and come back to Washington, D.C. on April 17th for our 11th conference. I'd like to thank also the incredible team that we have here from our host institutions. They've been remarkable, along with their tireless workers who have, their teams have been absolutely fantastic. Thank you for your incredible support for the conference. It's a sacrifice for you, and we thank you for being wonderful hosts and supporters. I would encourage you also to please go down and see all the posters and e-posters that are downstairs. We have 600 of them. They're remarkable examples of some great research that's being done around the world. I'd also like to thank our committees. They're all volunteers at CUGH, and CUGH wouldn't work without their efforts and the efforts of our board of directors. Finally, all of us know that we're coming into an important election period here in the United States. And while CUGH is not a partisan entity at all, but we have to be able to move policymakers to implement the great research that's being done. To do justice to the great work that you're doing, we have to be able to inform the public, because the public moves the political. And it's up to us, each and every one of us, and I want to implore you to think about how each of you could be a public scientist, to communicate the work that you're doing so that it can be taken up, it can be adopted into policy, and can be implemented. Because to produce research in and of itself is wonderful, but it isn't enough. We've got to breathe life into the work that you do and implement it. So in closing, a couple housekeeping issues. One is that the Continental room in your program is not on the second floor. It's on the lobby, as most of you have figured out. And then please also come to our reception tomorrow. Finally, of course, every year I have to do this, and that is take your picture, right? Because there's poor people who haven't been able to come here to our conference. It's so sad, and they want to be here. So I need you to welcome them, and I'm going to take, there you go, we'll take like the really conservative one, not politically conservative, but conservative. And then we're going to do the completely, we're hyped to be here, we're happy to be here, waving picture. Oh man, you're going to make a lot of people jealous. I'm telling you that. All right, so it's my great honor, folks, to be able to introduce our keynote speaker. When we wanted to have a keynote, we wanted to deal with, of course, somebody who could speak to one of the great gaps that we have in development, which is the strengthening of public institutions, and how scientists and researchers can actually work to collaborate effectively with the political class and with the public. And there's no better person, I think, that could do this today. This particular individual, she is a professor at the School of Public Health at Cayetana Herrera, Peru, Herrera University in Peru. She's a former Minister of Health of Peru, a former chief of the Peruvian National Institutes for Health. She's a leader, she's a mentor, she's an innovator, she's a recovering politician, and I feel your pain. And as always, and this is probably her greatest claim, I think, if I can personally say, she has always put the health and welfare of those who are least privileged at the forefronts of all of her efforts. So please give a warm welcome to our friend, Dr. Patty Garcia.
Well, thank you so much. I'm here on behalf of Cayetano Heredia University, and I hope that you eventually learn how to say it, Cayetano, which is the leading university in health issues in Lima, Peru. And we are a co-host institution of this CUGH this year. And I would like to start by giving you a warm welcome. So I'm bringing the heat wave from the south to you, okay? Yeah, it's so cold here, but anyway. So I was told that I should start by recognizing an incredible woman. And that there are so many women that are incredible, but there is one that really marked my life, and that was my grandmother. She died when she was 100 years old, and she was a chamana. So she was from the Andes, and she taught me so many things. She taught me how to pass the guinea pig to cure diseases, and I know that. So I know how to pass the egg to cure diseases, but the most important thing that she taught me is that you have to listen to people, because that's quite important. So I really recognize her as one of the strongest women that I have ever met. But I want also to recognize all the women in low middle-income countries that are trying and are fighting because they are trying to be scientists, professionals, physicians, and it's not that easy. And we are fighting against violence in our regions. So for them, please, an applause. So this is a special year for CUGH. We have been meeting for 10 years now. Academicians from the most prestigious universities. Initially at the beginning, mostly mature white men, but thanks God, now we have men and women, and we have also young professionals from all over the world. We are here to discuss all together how can we do it better for global health. And we have reached the point in which we are asking ourselves, okay, what is next? How can we translate and how can we implement it, whatever we do, to have real impact? I think this is a key moment in the history. Maybe the tipping point, because we are realizing that ideal things not necessarily work, and that research results don't work necessarily in the real world. So let's see if this works. So the reality is that we have been ignoring the elephant in the room, and that's why I decided to take these few moments to bring that elephant. As big as it is, as scary as it is, we have to talk about the C word that nobody wants to talk about. How can we, as researchers and academicians, can contribute to fight corruption in global health, which is a crucial challenge on these times? My main disclosure to make is that I'm not at all an expert of the topic, except that coming from a low middle-income country, I had to live all my life surrounded by corruption, which was actually, it has been seen for many as the normal status in those countries, or even as a coping mechanism. And I have even heard the word, or the two words, survival corruption for those with inadequate pays, and that is unacceptable. As a medical student, I saw things when I was at the hospital or at the health centers, things that the physicians or the providers or the practitioners were doing, things that happened with the medications, supplies that were disappearing. But since the health system was poor, and I'm talking about 25, 30 years ago, so there was not much to steal, really. However, when I became Minister of Health, I realized the magnitude of the problem, especially because there were more resources and there were more money. And when there is more money, there is more corruption. And that is the reality now globally. With more resources around the world, even from global funders, the whole world is erupting with corruption. 2/3 of the world is considered endemically corrupt, according to Transparency International. But you know what? Millions of people around the world are tired about that and are protesting against it every day. And there are lots and lots of honest health workers suffering from corruption. And they're suffering with burnout, but it's not because they are working so hard. That's not the problem. People that work in health in our countries are heroes, really. But they are suffering burnout because they are living the frustration of not being able to fight against corruption in the health sector. Corruption has a disproportionate impact on the poor and the most vulnerable. It increases the costs and reducing the access to social services and health. And corruption is deadly. Corruption is abuse and violates the rights of individuals and communities. And although there is no one comprehensive and universally agreed upon definition of corruption, everybody knows what corruption is. The UN, for example, do not even try to define it, but simply lists a set of practices that are deemed corrupt. Talk about bribery, extortion, theft, embezzlement, nepotism, undue influence. But how corruption started and spread? Well, it seems that corruption exists for a long time since social structures existed. But it is different between the North and the South. And actually, yeah, in the South we have a lot of corruption. But what happened? Where in the South we have the colonies. And the colonies were structured to exploit countries versus the governments that were created in the North to service populations and nations. Eventually, when countries became independent, what happened is that the structures remain, and it was not the colonial people, but the nationals who continued these issues of corruption. But one of the things that had happened is that in the past 50 years, corruption has become greater and greater. I said endemic, or we have had this eruption of corruption. And there are some theories that probably that relates with all the profound changes after World War II, and then in 1990 with the Cold War, which resulted in new countries, weak institutions that were vulnerable to abuse or misuse, authoritarian regimes, and also with the introduction of all these business people from North America and Europe that were looking for new markets. And in the South, they had those new markets. And they were trying to do business, but because there were weak institutions, things will take for very long. So they decided to start speeding things and trying to grease the wheels. And then we started having the corrupts and the corruptors. And that practice spread. And what happened with health? Well, health is a very attractive sector for corruption. So there are at least 5 main key actors in the health systems. The government, that usually is the regulator. The payer, that could be the government through Social Security, or could be the private or public health insurance. We can have other key actors, the suppliers, the ones that supply drugs or equipment, or the ones that supply construction, the providers, public or private, and also the patients. And all of these key actors interact in different ways. And in every of those interactions, we can see different forms of corruption: influencing, bribery, extortion, you name it. So it's true, health is an attractive sector for corruption, indeed, because there are multiple partners involved, and there is a lack of good record keeping. And there is a complexity between all these relationships that sometimes make us feel that it might be difficult to define if it is really corruption, because we have the really small corruption, the medium-sized corruption, the big corruption, and the large one, okay? But all of them is corruption. We are having systemic corruption in the health systems. And sometimes people try to hide it in inefficiency, or they call it honest mistakes. That could happen, but we have a lot of corruption. Every year, the world is spending more than $3 trillion on health services, most of which is financed by taxpayers. That's a lot of money. And the World Bank has estimated that because of corruption, societies, the whole world, is losing about trillions of dollars. Even more, it has been estimated that if we need universal health coverage for all the world, we need those $1 trillion. Corruption in health can mean the difference between life and death. So let me tell you very shortly one of my experiences as a Minister of Health. I started at the end of July of 2016, and it was just in September that this whole scandal started. So what happened is that one of the presidential advisors was found trying to influence, using his influence for lucrative contracts. Actually, this happened in September, so it was like 1 month I was minister. There were some audio recordings that were made public about a scheme to steer patients that were covered by the Peruvian government insurance into a private clinic that was owned by his friend. This guy was supposed to receive commissions for each person that received the insurance from the government, because we do have insurance from the government that was seen at a private clinic, even though the health services from the Ministry of Health could give the services. And actually, it was really a scandal. I mean, the guy was saying, it is our big business. I have the people to do it, and I have also the patients. We're gonna make a lot of money. And everybody knew this guy because he was a friend of all the politicians, or what you can call, he was the friend of the devil. So here, this is me, you can look at my face. I am with the Prime Minister, okay? And we were trying to explain the media, all the things that we were doing, okay? Because we didn't want corruption to continue. But one of the issues is that really and truly, corruption can damage anything that you do. And in the newspapers, this was the cartoon that came out. So the whole system was burned. We worked very hard, and actually, very soon, we were able to fire him from the Ministry of Health system, but it took a while, almost 2 years, first to convince the Peruvian College of Physicians to remove his medical license. Eventually, he had a civil court ruling, so he had to pay because he damaged the image of the Ministry of Health. And just recently, the anti-corruption prosecution has requested 5 years in prison. And then there were several things that we started to do, and if somebody's interested, you can ask about them, and I can talk about that later on. But the thing is that I start thinking, hey, this is something that we need to do. We need to do something, okay? So I started to look at what has been studied about corruption control, okay? And there are lawyers that are studying that. There are some anthropologists. There are politologists. And so there are at least 2 theories about how corruption in general could be controlled. One started in the late 90s. Transparency International was behind it. And they talk about the need of having strong institutions, okay? And they talk about the need of having a national integrity system, which is a way, it's kind of like a holistic approach to prevent corruption, in which we can have different institutions all working together in perfect harmony, okay? And if you have them, then people would not be even tempted to do anything. And they even have this beautiful Parthenon, okay, with all these columns. And actually, in the late 90s, Peru followed this. We even have an ombudsman, and we have everything, but still we have corruption. The other theory had to do with social norms, or the way people think. And I thought this was very interesting. So they were trying to study how people will process rule breaking, or the decision of an individual to engage into corruption. And this is the formula. And this reminds me what I have seen I'm an infectious diseases doctor, and I work in sexually transmitted diseases. So we have this formula that allows us to describe when an infectious disease or an STD will spread in a population. So I thought it was interesting. So what you can see here is the B is the perceived benefit of a corrupt act. So if the B is big or the other factors are small, then people will decide to go and do the corrupt act. And what are the other factors? Well, one has to do with the psychic costs. How do I feel about doing something that is wrong? And of course, that has to do with the values, what you have learned, what is surrounding you, okay? And if you are in a community where you consider that normal, or you consider that corruption is a way of survival, that C is really small, okay? And then you have this perceived probability of these two other C's. The criminal costs, which means has to do with the society and the judicial system, okay? Are you going to get punished? And the social costs, how are people going to see you if you are doing corruption in where you are, okay? Plus this other factor, the cost of doing the favor or the corruption. Is it easy? Okay? So this is a very interesting way to see it. But the conclusion is that probably we need to think about both things, because institutions are made of people. And in a way, we have to assure social norms through institutions. So there is a long way, but there are things that we need to think that we have to work on in the countries. So because I am an academician, although I was Minister of Health at that point, and I'm a researcher, I decided to look for the evidence on what could be done for corruption in the health sector. And I decided to look into PubMed for the term corruption. And I was shocked to see of the scarcity of the publications. And I even looked at each of the publications, and most of them were not talking about corruption, really. Okay, somehow they have the name, but there was nothing about corruption. So I decided to compare that with another term, with breast implant. Well, there is a lot about breast implant, okay? And, well, I decided, well, let's see something that is more meaningful, HIV. Well, there is a lot about HIV, and you can hardly see what is happening with corruption. But I found one article that I thought it was quite interesting, which was a Cochrane Library review, okay, about interventions to reduce corruption in the health sector. And I got very excited. So the primary objective of this article was to try to summarize the empirical evidence of the strategies to reduce corruption in the health sector. And they were looking for RCTs, then non-RCTs, well, at least time series studies. Okay, well, even before and after studies. But they have a secondary objective also to try to describe what has been tried, at least case studies. It was a very, very comprehensive evaluation. They searched for 14 electronic databases, 23 websites, and online databases on gray literature. They did that in 2015, and it was published in 2016. Unfortunately, no studies met inclusion criteria for primary analysis. And they work hard, okay? I guess if doing all this work for no conclusion. So they look, and they found 9 studies that they thought they could do some secondary analysis. 5 were from the US, 1 from India, 1 from South Korea, 1 from Kyrgyzstan, and 1 from Germany. But the thing is that all these studies were describing some type of institution that was doing investigation and sanctioning, or some sanctions directly, but none of them showed any type of effect. They were not measuring anything. So the big conclusion was that there is a need to evaluate effects of strategies to fight corruption. And there is a need. So when we talk about global health, I think we all are thinking about how can we transform global health? How can we do it better? And we talk about strengthening health systems. What can we do with human resources? What about the whole issue of public health? What about modern and interconnected health infrastructure using technology? And for all of that, we need to invest in health. But we cannot ignore that we have to fight against corruption. And this is my pledge, guys. Since I was Minister of Health, I have been going around looking for people that are doing research. I found two people that, I have seen that they were doing some research, I told you, in law schools, but it has nothing to do really with health. It's in general with the business, with business companies, because they have seen that they lose money because of corruption too. There are some people in Canada. Canadians are always very nice, so they're interested in doing research. WHO has an area, but they are not even brave enough to use the word corruption. They call it governance, okay, it's behind there, it's corruption. So I really think that we need to start addressing this elephant, and we need to do research on interventions to reduce corruption in the health sector. But every time I talk about corruption, then the questions arise and they said like, aren't you scared of being killed or something? Well, yeah, when I was minister, initially I didn't want to have any guards, but eventually I had to have, because I received things in my house, people looking, there were so many things, but I'm not asking you to expose yourself. I think as researchers, we can start small and try to think out of the box. How can we really start thinking how to make the system more transparent? How can we make things better? How can we involve the community to be part of a surveillance system against corruption? There's so many things that we should think. And I have to tell you that I have seen even researchers trying to ignore the fact that there is corruption and without calling it, paying bribes for people inside the system to allow them to move things. Because we have timelines in research, and that's not acceptable. Let's try to think, how can we do research on interventions to reduce corruption in the health sector? So this is me for the final reflections. So societies are losing trillions of dollars due to corruption. And I told you, those trillions could give universal health coverage to the world. Health systems are immersed in corruption, and we need to do something. The first thing that we need to do is we need to change in all those books the idea that the health system is perfect, with all these wheels that work all together, okay, engaging, like a watch, right? Well, if you have a watch that is not waterproof and you put it in water, it doesn't work. So that's our health system. Our health system is not working because we're trying to put this ideal thing into this real scenario, which is corruption, and that's why it's not working. So it is our responsibility in global health to create the knowledge. That's what we do better. Political will is needed, of course, but you know, political will is not only politicians, it's people. It comes from below, and I show you, people are screaming, okay, because everybody's tired of corruption. So times are changing, people are pushing, but what we are lacking is the knowledge of what interventions work and what can we do, and we can start small. We need research and interventions that can reduce corruption in the health sector. Maybe think about accountability, transparency, better information systems, use of technology, electronic medical records. And now I know that there are some people that are against electronic medical records because that will make things much more clear and transparent. We need to involve the community, the power of people. We improve delivery services, clear channels for allegations and sanctions, and let's try to measure those things. And we need funding to do research about corruption. Nobody talks about it. I mean, we need funding for that too, and we need researchers interested. So let me read this for you, because I was reading a book, and I never thought I was going to find this, but I think it's quite interesting. I'll tell you something my father told me when I was a young man. Apu said, "My son," he said, "the greatest force in life of this country is not the government or religion or the entrepreneurial instinct. It is the bribery and corruption." He said it like one word, like electromagnetism. Without bribery and corruption, nothing would happen. It is bribery and corruption that oils the wheels of the nation, and it is also the solution to our nation's problems. If there is terrorism, sit down across the table with the terrorist boss and sign a blank check and push it across the table. And say, put as many zeros as you like. Once he has pocketed the check, the problem is over, because in our country, we understand that there is honor in bribery and corruption. Once a man has been bought, he stays bought. My father was a realist. And this comes from the Golden House from Salman Rushdie. I don't want to believe that the world is like that. It is, but it should not continue like that. Corruption is an insidious plague that has a wide range of corrosive effects on societies. And we as a community, a global community, we need to give what we know, okay? We can create knowledge, we should do research, we should not be afraid, okay? We can do it because we deserve countries with no corruption. We all do. Thank you so much.
So I have to say one thing that probably epitomizes Dr. Garcia's amazing, inspirational speech that she just gave us, and it was given by Dr. Holmes, who was one of the mentors for Dr. Garcia. So Dr. Holmes leaned over to me and he said, "Now that's a courageous speech."
Thank you, King. Thank you.
And given what Patty has seen in her life in terms of being a researcher, a scientist, and a politician trying to apply her knowledge to improve the lives of those who are least privileged. And if you have a chance, speak to her about her work in cervical cancer. It's incredibly inspiring. Patty, we are grateful for you being here. We're grateful for you being a friend of CUGH. We're grateful for what you are as a mentor, as a leader, and what you continue to do to inspire us to do better, to be better at what we do, and to deal with this cancer that's actually eviscerating the ability for all of us to help those who are least privileged in this world. And I think it's important for all of us to recognize from high-income countries that that money that's stolen from low-income countries, they're not parked in low-income countries. They're parked in high-income countries. So we're as much of the problem as any other country. And as you said, Patty, we're all in this together. So again, thank you very much again for being here. You're awesome as always.
Thank you. Thank you. No questions, huh? Okay.
And if the next panel could come up now, that would be wonderful. Panel number 2. Thank you.
Okay. To the hand, and I'll just use the hand.
I'm the final panel of the day who gets to say good morning, everyone, with 30 minutes remaining in the morning. If you could take a seat after you've stretched your legs, our lunch break will be after this plenary panel. It's truly a pleasure to be here today moderating a plenary panel on interdisciplinary perspectives on a rights-based approach to global health. My name is Juliet Sorensen. I'm a professor of law at Northwestern University and the director of the Bloom Legal Clinic. One of my areas of focus is health and human rights, and I work closely with my colleagues at the Center for Global Health, directed by Dr. Robert Murphy, whom you heard from this morning. Truly, my remarks this morning are not what I expected them to be. As I contemplated the issue of interdisciplinary approaches to a rights-based approach to global health, I anticipated saying something, frankly, somewhat self-congratulatory. A description of my efforts and, in part, my successes at breaking down barriers to realize impactful interdisciplinary collaborations in furtherance of a rights-based approach to health. I plan to describe to all of you, before introducing our illustrious panel, the work of the Northwestern Access to Health Project, a global community-based partnership between Northwestern's medical, law, and business schools and communities around the world at the intersection of health, human rights, and development. Specifically, I thought I would speak to you all about our work in Lagos, Nigeria, where in partnership with the Federation of Slums and Informal Settlements of Nigeria and a local NGO, we have designed and implemented a first-of-its-kind curriculum to train community health educators in the slums and informal settlements of Lagos on public health topics identified by the community to optimize health education and access to care. I thought I would speak to you about our investment and mentoring of our local partners, one of the aims of the initiative. Those are not the remarks I will be giving, but aptly, my remarks reflect my hero on International Women's Day. Until this week, your program stated that one of the speakers on this panel was to be Oluwatosin Sarah Osho, a community health educator from Lagos, Nigeria. Osho, my colleague, is a gifted communicator with 10 years of fieldwork experience working in 85 communities in Lagos, a megacity of 23 million people. She is passionate about improving health access for the most vulnerable members of the urban poor communities in Nigeria. Osho was to spend the week here meeting with our partners in Chicago, at Northwestern, at UIC, and at a social impact consulting firm that works with us. Our plans were upended when Osho's visa was summarily denied at the US consulate in Lagos, without regard to her itinerary, her official letters of invitation, or other corroborating documentation that she had brought with her. There was no avenue to appeal, notwithstanding the efforts of our university working with our member of Congress. Osho is my hero on International Women's Day, and as I turn to the content of this panel, I need to ask the questions. How can we engage in a comprehensive discussion about breaking down barriers when a barrier is arbitrarily imposed? How can we talk about meaningful partnerships across silos when one key partner is forcibly siloed and unable to engage in that discussion? How can we discuss the realization of the right to health when our own colleague was subject not to what I, as a constitutional and human rights scholar, would term due process of law, notice, and the opportunity to be heard, but rather arbitrarily rejected? I've always thought that my perspective on a rights-based approach to health is that of an idealist without illusions, a phrase first coined by President John F. Kennedy. And I continue with that attitude. I continue to advocate to break down barriers using my best efforts, including barriers that impede a truly participatory conversation about a rights-based approach to global health. So I'm proud to acknowledge Osho as my hero on International Women's Day. I wish he were here today. But with that said, I know that the members of our panel will further this meaningful conversation about a participatory dialogue in breaking down barriers to a rights-based approach to health. From here, I'm going to pivot, and I'm going to introduce each member of the panel to be followed in succession by their remarks. I'll be posing some questions, but rest assured we are going to save 15 minutes at the conclusion of our session for questions from the audience, so I encourage you to think about them. We're going to begin by hearing from Professor Lawrence Gostin. Larry is university professor at Georgetown University, and he's the founding O'Neill Chair in Global Health Law. He directs the WHO Center on Global Health Law and co-chairs the Lancet Commission on Global Health Law. He is a member of the National Academy of Medicine and serves on the Global Health Board. Both the National Academy of Medicine and the American Public Health Association awarded Professor Gostin their Distinguished Lifetime Achievement Award, and his book, Global Health Law, which, by the way, speaks to, among other issues, corruption in the health sector, and I can personally recommend it to folks in the audience, was published by Harvard University Press and is translated into Chinese and Spanish. So before I introduce our remaining panelists, welcome Professor Gostin.
Thank you very much, Juliet. That was really a lovely introduction. I really appreciate it. So today is International Women's Day. So this morning, with a session with Ben Meyer, and we talked about global health governance and human rights. And for that session, I chose Gro Harlem Brundtland as my heroine. And I was thinking last night while I was asleep, there's probably no human being on the planet that saved more lives than her through her pioneering work on the Framework Convention on Tobacco Control. Just think what she did. But for today's session, and for probably quite obvious reasons, my heroine is going to be, I think, the greatest First Lady ever, Eleanor Roosevelt. For those of you who haven't gone to the Roosevelt Memorial in Washington, it's truly remarkable. So what I'm going to cover today is the golden era of 1946 to 1948, when Roosevelt was active, the Great Generation. Then I'm going to move to today, the sad story of nationalist populism, xenophobia, separating mothers and children at our southern border, and much more. I'll then look at how the right to health does affect health and how human rights and health are intertwined, and I'll look at 3 different meanings of universal health coverage. I'll then talk about how the human rights movement can succeed today, borrowing on the historic work of the AIDS movement. And then I'll take us full circle to what I hope is a hopeful future. So when she was signing the Universal Declaration of Human Rights, which was 70 years ago today, not today, in December, we wrote an article in the Lancet commemorating that with Dr. Tedros. Eleanor Roosevelt said, "Human rights are grounded in small places, close to home, the places where every man, woman, and child seeks equal justice and dignity." So what did she mean? She was coming from what I call the golden era of modernity. In 1948, the United Nations in the post-war era adopted the Universal Declaration of Human Rights, which stands as the most important document today There was the UN Charter that meant that the world of nations was defending human rights, peace, and security. And just 2 years earlier, the UN had designated its first United Nations specialized agency, the World Health Organization, and the WHO Constitution has the right to health as its great mission. So for Eleanor Roosevelt, human rights wasn't a sterile theory, it wasn't a form of international law, but she felt that at the very ground, human beings, individuals, families, communities, trades unions, and others, civil society, that's where we ground human rights, and we sometimes forget that. And if there was ever a generation that has forgotten, it's our current generation in this world of nationalist populism. If you think about what we stand for as a health and human rights movement, what we stand for as a global health community, much of the signals and symbols of modern populism rejects that. They reject the idea of mutual solidarity, where each of us owes a duty to one another around the world. They reject the idea of strong and robust global institutions. They reject the international rule of law. They reject the idea of universal rights and freedoms, including the freedom of press and the freedom of civil society to act boldly and aggressively. And they even reject something that's the most important to every single one of us here, which is the rule of science and evidence, that all things should be evidence-based. This morning, I had an op-ed with other global health professionals in the Washington Post talking about measles outbreak in the United States and the anti-vaccinationists' denial of science. But we can also see that with climate change and so many other areas. And it also reminds me of something that the White House and HHS put out where a year or so ago they told the CDC that they couldn't use certain language in their budget appropriations, language like science-based, evidence-based. And then when I pushed back against that, HHS and the White House said, yes, but it was only friendly advice to the CDC about how to get a better budget. But that was even worse if you actually think about it. And why was it worse? Because the people in Congress who are there to try to advance the public's health, security, and safety, why wouldn't they want to know about evidence? Why wouldn't they want to know about what works? And here we are today fighting the second greatest outbreak of Ebola ever in the Democratic Republic of Congo. And I think this signals a new era about how we're dealing with health emergencies. And I've been writing about this in The Lancet and other places. If you look at places like Syria, Yemen, Somalia, northern Nigeria, the Congo, you're seeing complex humanitarian crises where because of a generation of denial of human rights, of torture, of violation of freedoms, we're seeing a backlash. And now communities simply don't trust government, and they simply don't even trust WHO and first responders. So from Dr. Tedros's point of view, and I think he's exactly right, all roads, in his words, lead to universal health coverage. And that's where I think human rights converge at its heart with health. Unfortunately, I think we've got three quite different meanings of universal health coverage that have currency, and we need to really have a much more robust right to health view of those. One, of course, is the Sustainable Development Goals by the United Nations. if you actually read those, that target of universal health coverage, it says nothing about social determinants of health. It says nothing about population health, public health, surveillance, clean water, clean air, sanitation. It's all about health care. And health care is important, but it's not enough. The WHO definition of universal health coverage does include all of that, but there have been no funding, very little political advocacy around social determinants of health and public health. And then if you look at the international health regulations, it's looking about health security and strong health systems, laboratories, surveillance, and the like. And so I just came back from Geneva where Dr. Tedros had announced a major realignment of WHO. And one of the beautiful things about that, there were things I disagreed, but one of the really nice things was that he brought the human rights work of the agency into the Director General's office to mainstream them. So how can the health and human rights movement succeed, particularly in the era that we now live in? I believe that the only way is bottom-up social mobilization. If you asked me what is the greatest weakness historically of the World Health Organization, I would say it was the failure to capture the love and attention and passion of civil society. I was not too long ago in South Africa, and I decided everybody was wearing in-your-face AIDS t-shirts, so I put on my WHO Right to Health t-shirt. I was booed because people just didn't trust the World Health Organization, and that's sad. But if you think about the Global Fund and all that civil society do to push replenishment, you'll see a better way. This session is a lot, as Julia had mentioned, about Jonathan Mann, the great pioneer of the AIDS movement and the health and human rights movement. And when I was quite young, I went to WHO and Geneva, and my friend Seth Fluss, who was the head of health legislation, said, there's this young American there, and he's there for the global program on AIDS. And I went to see him, and the global program then was just John and one Swiss secretary, and of course it grew to be the greatest program in the history of the World Health Organization, amidst a lot of political controversy with Director General Nakashima. But I kept going back and I said, John, how are you going to deal with this? And first he said, well, the standard public health response. I was at Harvard then, went back, came back and said, John, it's not going well. How are you going to deal with it? He said, harm reduction, needle exchange, condoms. I went back to Harvard and came back to Geneva and I said, John, it's not working. What are you going to do? And he said, the only thing we can do is to advance and advocate for human rights, and particularly the rights of women. And to me, that was the birthplace of the modern health and human rights movement. So today, I want to suggest to you, despite all the dispiriting news that we hear around the world, we do have a hopeful future. Juliet was kind enough to mention the Lancet Commission on Global Health Law, which is coming out in April. And that is going to be based upon human rights and the rule of law. We've been pushing with WHO and the United Nations for a framework convention on global health, modeled very much on Gro Brundtland's framework convention on tobacco control. And that is a universal treaty based upon the right to health. And then finally, we're about to launch something called the Equity Program of Action. Because if you asked me what is the greatest unmet pledge of the Sustainable Development Goals, I would say it's their pledge of leaving no one behind. Because although we've made enormous advancements in global health in terms of absolute health improvement in longevity, child maternal survival, people living with AIDS on antiretroviral medications, and so much more, the actual gap in health between the rich and poor, both within and among countries, is still shocking. After the MDG era, the life expectancy between low and middle income countries was 18 years. Today in Africa, less than 30% of poor women have skilled birth attendants, and I could go on with so much more data. So I will just conclude by saying that despite all the sad news, many of you are young. You're the future leaders, and I would urge you to not be dispirited, but to really fight. Human rights and health just won't happen. AIDS taught us that you have to have uncompromising social action, and it's the only way forward. So not to be dispirited, but to actually be heartened, because if we put human rights as the heart and the soul of global health and put the right to health at its very center, there's no end of the progress that we can make for the rule of law, for freedom, and for leaving no one behind. Equity, dignity, and rights, and that's our future. Thank you.
Well, thank you so much, Larry. And your stirring remarks also present an opportunity to transition from global to local, so to speak. As you said, Jonathan Mann held the view that harm reduction was a human rights-based approach to health. Eleanor Roosevelt said that human rights are grounded in small places. Our next speaker has brought her advocacy from the ground up, from practice to policy, and vice versa. I'm so pleased to introduce Gabriela Zapata Alma. She's the Director of Policy and Practice for Domestic Violence and Substance Abuse at the National Center for Domestic Violence, Trauma, and Mental Health, as well as adjunct faculty at the University of Chicago. Gabriela brings over a decade of experience working with survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, gender-responsive care, housing first, and other behavioral interventions. Gabriela has been recognized with the Health and Medicine Policy Research Group's 2018 Health Award and the Illinois Association of Addiction Professionals 2017 Rising Star Award. Please join me in welcoming Gabriela Zapata Alma.
Hi, everyone. Good morning, afternoon. Such an honor to be here. And so, in naming a woman who inspired me in honor of International Women's Day, of course I can't just pick one, and so I would like to honor las hermanas Mirabal, the Mirabal sisters, Patria, Minerva, Maria Teresa, y Dede, who fought to overthrow the brutal dictatorship of Trujillo and who made the ultimate sacrifice on November 25th, 1960. And in their honor, the UN dedicated in 1999, November 25th, to be the International Day of Elimination of Violence Against Women. Do I have a clicker? One moment.
Is there someone from IT who can help us?
Is that it?
I don't know. Let's try it. That doesn't look like it. Nope, that's the same.
Oh, yeah.
Did that work?
Excellent.
That worked. All right.
Thank you.
There we go.
Minor detail. Show me how to do it.
It's the big green button.
Oh, perfect. It's the big green button. Imagine that. So, the National Center on Domestic Violence, Trauma, and Mental Health, we are the funded special issue resource center dedicated to addressing the intersection of domestic violence, trauma, substance use, and mental health through a comprehensive array of training, technical assistance services and resources, research and evaluation, policy development and analysis, and public awareness. So what do we know? Rights-based health approaches require us to address the social determinants of health while centering the perspectives, voices, and experiences of individuals and communities who are most adversely impacted. And so I'm here to offer you some experiences from the field. First, Pathway, a peer-led alternative transitions to housing. Daybreak, also known as the West Side Narcotics Diversion and Treatment Initiative. And then Healthy Mom, Healthy Baby, advocating for pregnant women amidst an overdose epidemic. So first, Pathway. I was very proud to be a part of Pathway during my time at Chicago House, the first provider for housing for people impacted by HIV in the Midwest. And so defining the need, pervasive discrimination against individuals living with HIV, as well as pervasive discrimination against individuals who are unstably housed. And we also know that supportive, affordable housing is a scarce resource, and at that, a resource that is very difficult to access. We also know that unstable housing increases the risk of contracting HIV, as well as the risk of dying from HIV and AIDS. 7 to 9 times increased risk. We also know that housing is healthcare. Housing is the foundation of health. And especially for those living with HIV. Housing need drives these health disparities. Housing is the greatest unmet need for people living with HIV. And I already mentioned that last piece. I got ahead of myself. So, our response to this crisis, a peer-led intervention where all of our outreach workers were openly living with HIV as well as formerly homeless, and used their experiences to engage and inspire individuals in their own housing placement. Something we learned is that a warm handoff wasn't enough. The ongoing support was critical after housing placement. And through that ongoing support, we were able to achieve 100% of people retained in housing with up to 24-month follow-up. We also saw housing as healthcare in practice, that we were able to link 100% of individuals served to HIV medical care and have them retained in medical care. So in the words of one of our Pathway program graduates, Pathway helped me get involved in my own life again. He didn't do things for me. He showed me how to help myself. So moving to Daybreak, looking again at the need amidst our climbing overdose epidemic. So something about here in Chicago, our rates of fatal overdose over double the national rate. And the communities with the highest rate of fatal overdoses also experience disproportionate rates of arrest and poverty. And while arrests for heroin possession were decreasing citywide, they were increasing in the communities most impacted by fatal overdose. And so one example of one such community, the West Garfield Park neighborhood, had a 20 times higher rate of arrest than the city average and 2,000 times higher than Lincoln Park. There's my fair city, and you can see very clearly the western part of the city that is disproportionately impacted. And so in 2017, we saw continuing climbing overdose fatalities, especially within communities characterized by high rates of economic hardship and disproportionately impacting Black Chicagoans. Also looking at the criminal legal system, those detained in our jail tested positive for opioids at a rate of 19 times higher than any other area in our nation. And justice involvement, legal involvement, does not address the root causes or needs related to substance use issues and risk for fatal overdose. Instead, they're another driver of health disparity, social determinants of health, and increased overdose risk. And here in Chicago, there's a growing body of evidence linking our opioid crisis, our overdose fatalities, and gun violence. So now getting to Daybreak, our core elements and outcomes. Still in a pilot phase, partnership with Chicago Police Department as well as the DEA was critical. We designed the project to be pre-arrest so that the arrest does not stay in the record. We also offer availability of walk-in services because the last thing we want is to incentivize arrest or make arrest somehow the portal to accessing health resources. This model uses an interdisciplinary team of clinical, harm reduction counselors, as well as recovery coaches. And a recovery coach is a person in long-term recovery who provides community-based services, including outreach, engagement, resource advocacy, and wraparound support. We also found that a big predictor of engagement and progress was same-day access to medication-assisted treatment, specifically buprenorphine and methadone. Something we know to be true, the hallmark of a substance use disorder is continued use despite consequences. There is enough punishment in the drug use itself. We're not going to arrest or punish our way out of this epidemic. So now looking at healthy mom, healthy baby, advocating for pregnant women amidst an overdose epidemic. So, sometimes we love to tell people things they already know. And so I say this, people know that drug use is not healthy during pregnancy. And people are naturally more motivated to engage in health care when they are pregnant. And so those who are unable to stop using, by definition, meet the criteria for a substance use disorder. Something that's very clear in the evidence is that outcomes for mom and baby are better when they are together and they have access to the proper supports. A little bit about what we know about individuals who are pregnant and continue to struggle with substance use. Many of them didn't plan to become pregnant. They found themselves here. Many of them also have a co-occurring mental health condition, have experienced childhood physical and or sexual abuse. 2/3 had parents who also use substances, so really indicating the need for social support and positive role modeling. And many had increased rates of intimate partner violence in the past year. Something else that is clear in the evidence, the link between intimate partner violence, trauma, and substance use. And so when we are clear on this link, then we can be clear on what interventions are needed to support women who are pregnant and continue to use substances. So part of this intervention, we know, needs to include medication-assisted treatment. Medication-assisted treatment is critical for pregnant women with an opioid use history. Ooh. And detoxification is counterindicated. Where can I find medication-assisted treatment? Where, oh where, can I find medication-assisted treatment? Very difficult to access, especially when we layer on top of that all of the barriers of stigma and discrimination. We also know that health outcomes for baby are much better when baby and mom are kept together. So the current standard of care includes extended skin-to-skin, kangaroo care, rooming together at the hospital, and breastfeeding, especially when mom is accessing medication-assisted treatment. But then looking at our policy environment and access to treatment, we know what works, but can we get it? So 23 states in the United States, as well as DC, consider substance use during pregnancy to be child abuse. 3 states consider it grounds for civil commitment for up to 6 months. Only 19 states have either created or funded treatment programs specifically designed to serve pregnant women. Only 17 states and DC have prioritized access for pregnant women. And only 10 states protect pregnant women from discrimination in publicly funded programs. So as a pregnant woman who uses substances with a life-threatening condition in the United States of America, I am more likely to be criminalized than to have access to evidence-based, effective health care. So coming back to our map of medication-assisted treatment, and then now looking at all the places where I would be criminalized for having a substance use disorder, including the state of Illinois. So with that, I leave you with this. The opposite of addiction isn't sobriety, it's human connection. Shame, discrimination, criminalization, and lack of access are all drivers of our current overdose epidemic that has sweeping adverse effects across generations. Instead of adding to the punishment of substance use, we need to focus on human connection, engagement, increasing protective factors, and developing recovery capital. And people who use drugs, as well as those in recovery, need to be at the center of our movements. And, in the words of Dr. West, never forget that justice is what love looks like in public. Thank you.
Thank you so much, Gabriella. So Gabriella's brought her deep community-based experience to evidence-based policy advocacy that I hope to return to during the Q&A. And we'll now pivot to a different community-based focus and someone who brings equally deep expertise from a different perspective. Kelly Leeson is an independent consultant leading the Refugee Self-Reliance Initiative with Refuge Point and the Women's Refugee Commission. She has over 15 years of experience working in East and West Africa, Latin America, and Russia, designing and leading health, education, and livelihood programs for the displaced. Kelly served as country director for Kenya and deputy regional director for East Africa with the International Rescue Committee and as managing director for New York University's Development Research Institute. She has held positions with Concern Worldwide and the American Institutes for Research and was the initiator and architect of the IRC's Urban Refugee Initiative, where she developed urban programs, partnerships and platforms and presented on that topic. It was this work with urban refugees that led to Kelly's current interest in self-reliance, including the creation of the Wellbeing and Adjustment Index and co-founding the Refugee Self-Reliance Initiative. Kelly, welcome to CUGH.
Good afternoon, everyone. And thank you so much, Juliet, for including me here today. My work is not exclusively focused on health at all, and so it's really great to see a panel looking at holistic approaches for better health outcomes for clients. And Gabriella, it's great to hear about your work as well, because I think we came from the same perspective of identifying an issue and being able to find solutions together with clients. And so one of the things that I'm really focused on is this idea of self-reliance. And so I'm going to spend a moment describing the Refugee Self-Reliance Initiative, an initiative focused on promoting refugee self-reliance. So I think it brings together the two worlds that Larry spoke about, but also Gabriella, but also talking about the creation of this alliance and what we're doing, and finally how this then pivots back to health. So, as Juliet mentioned, I worked for many years with the International Rescue Committee, and I was based in Kenya for about 10 years. And as the director of the program there, I was overseeing a big healthcare project in the Dadaab refugee camp, the Kakuma refugee camp. But at the same time, I was acutely aware that there were tens of thousands of refugees who are also living right down the street in Nairobi, in the capital city. And so we started some small programs working primarily with Somali refugees, many of whom had been in Kenya since 1992. Now think about that, 1992. So this was 2009. So many years later, there were still refugees living in Nairobi who still didn't have their feet on the ground because services weren't being directed at them. So we were doing some small programs focused on savings, small business development, and really trying to make the connections for those refugees with basic services. But at one point, I went out to see some of our programs, and I asked the program manager what is actually an unfair question. I asked her, is this client's life going to be any better in 10 years or in 3 years' time because of the work that we are doing? And she couldn't answer the question. And like I said, it was unfair because we were not explicitly trying to answer that question. Our programs were so focused on short-term outputs that we didn't know if all of what we were doing was going to add up to someone's life being better in a couple of years' time. And so that really got me thinking that we really needed to be looking differently at what we were doing, so we could be thinking about how we can help refugees to regain their agency, to regain their dignity, and to regain their lives. So if we zoom out from that small experience in Kenya to think about refugees globally, we know, according to the UN High Commissioner on Refugees, that currently there are about 25 million refugees in the world, of 68 million displaced. About 50% of those refugees live in cities, like probably many of us here. And while time frames fluctuate, many refugees are in long-term protracted situations. So like I said, in Kenya, many of the refugees arrived in '92, some arrived in 2010. The Syrian crisis, which now seems, like it's been going on since 2011, 2012, that seems very current, but in actuality, that's been going on for many years. And then if you think about the Afghans have been in refuge in Pakistan and Iran since the 1980s. These are people who have been living in protracted situations for many years. And only in 2016, we know only 3% of refugees have access to a long-term permanent solution. So many refugees globally are languishing for years. And I would guess that if many of you conjure up an image of what you think about a refugee, even if you know what the reality is, your first image is of somebody crossing a border, a dusty refugee camp. And I have to say that there are those experiences, but as noted, many refugees are living in quite different situations. But it is in those refugee camps, in those emergency settings, that a lot of our great work has been developed. And so in terms of the humanitarian field, we now have excellent skills in targeting households for food distributions, high tech. We know how to run vaccination programs in emergency situations, and we can construct shelters in the middle of nowhere, in the middle of deserts, and it really is very impressive. But if we come back to what I said earlier, many refugees are in cities. They're in protracted situations. So there's a context that needs a different type of development, different approaches, different tools, different standards. And as I watched Gabriella's presentation, I was jealous of all the evidence she has about what works and doesn't work, because we are really just at the start of finding out really what works in protracted situations. So this is what the Refugee Self-Reliance Initiative is trying to address. We're trying to address the situation of protected situations. And I often think of this quote from former UN General Secretary Ban Ki-moon, that we are able to keep people alive with our emergency responses, but very rarely are we able to help people to thrive in their situations. So the Refugee Self-Reliance Initiative is trying to reframe what we're trying to achieve when we're engaging with refugees, to move beyond that basic survival mode, to help refugees to restart their lives in their either temporary or permanent situations. And we're built on the foundation of international refugee law, the 1951 Conventions on the Status of Refugees and the 1967 Protocols. So in addition to codifying the fundamental right to seek asylum, the conventions also say that refugees should have access to basic services. Refugees should have an access to be able to have gainful self-employment or wage employment, even though that's denied by many countries still today. More recently, in December 2018, the UN member states adopted the Global Compact on Refugees. This includes objectives on easing pressures on host countries while also making sure that refugees have access to self-reliance and can seek self-reliance. So even with these foundations, we have the rights foundations. The unfortunate reality is that most refugees still face enormous challenges and obstacles to providing for themselves and their families and really being able to think about their futures. So going back to my initial story, thinking about this program in Kenya, it was evident there was this huge gap in how we were approaching refugee programming. And so I was able to partner with a colleague at the Women's Refugee Commission, and we created a tool to measure self-reliance and to try to begin the process of figuring out what are the key components of self-reliance and how can that actually be measured, thinking of that old adage, that which can be measured can be improved. This effort has now grown into the Refugee Self-Reliance Initiative, a global multi-stakeholder initiative made up of about 20 members of global organizations, including Mercy Corps, International Rescue Committee, IKEA Foundation, the State Department, and of course the UN High Commissioner on Refugees. We're trying to identify how it is that we can do better programming to really help refugees get back on their feet, with the idea of self-reliance being the social and economic ability of an individual or a household to meet its essential needs in a sustainable manner. And our initiative has three components: measurement, programming, and advocacy. As I mentioned earlier, we were trying to measure self-reliance with this Well-Being and Adjustment Index. This is now morphed into the Self-Reliance Index, and we're piloting that in Kenya, Mexico, and Jordan. And it's hard. I understand why people haven't done it before. We've been working on this for the last couple of years. I'll be going to Kenya tomorrow, actually, to continue with this pilot. Every time we think we've got the right question, we're asking it in the right way, we test it out, we work with refugees, we work with practitioners and find out, no, we're not quite there yet. So it is a process, but we are really committed, and our partners are committed to helping us to get this right because we know it's important. Because we know this will help us to get to better programming. And we know that, anecdotally anyway, because we really have very little evidence about what helps people to get to self-reliance, anecdotally, we know we should be looking at longer-term time horizons. We think we should be looking more concretely at holistic approaches. And these are big shifts for the humanitarian community who is so focused on sectoral approaches. So somebody does healthcare, somebody does shelter, somebody does nutrition, and very rarely do those areas come together. Just as Gabriela was presenting and talking about how housing is so important for healthcare, these are the same kind of situations for refugees, as you can imagine. We need to be able to find out how do all these different pieces add up for people to achieve self-reliance. The third component is advocacy, coming back to the right side of things. Refugees should have these rights. They should have the right to seek basic services. They should have the right to work, and many times they do not in countries that we work in. And so we have to keep up the pressure on hosting governments and work with donor governments to try to change laws, change restrictions. And I know these are not easy situations. Talking about what Larry mentioned earlier about populist movements, there are a lot of countries that want to keep refugees out, and there are political reasons why that is happening. And so coming back to why all of this matters for health, if we're able to look at self-reliance, we're able to look at things more holistically. And there are a couple of areas that we've been focused on. And so first and foremost is exercising one's rights. An example of one of the countries that we're piloting in Mexico, our partner organization is Asylum Access. They do legal aid services, but by using the Self-Reliance Index, which looks more holistically at what's happening in the household, they started asking people, what's your access to health care? And people were talking about how they were refused health care at the public health center, how they were discriminated against. And Asylum Access then could take that information and probably, or potentially, the administration at the health services didn't even know that refugees had the right to seek those services. So they were able to formulate a program of advocacy to work with the public health system to make sure that people could have the access to health care that were legally their rights. Also in terms of inclusive societies, thinking about the fact that we don't need to create parallel systems in a number of places, including cities. We can just make sure that refugees are part of a system. And so an example from Kenya, where a refuge point, where they were able to, even though the rhetoric in Kenya is very anti-refugee, they were able to work with the municipal authorities who understood that refugees should have access to the public health insurance policies. And so they shared that information with refugees and helped them to sign up. That's not a parallel system. It's just making sure that refugees have access to a system that already exists. And also participation in society. We know from experience in Jordan that there are a number of children who have disabilities, and because health subsidies had been cut, they no longer could afford to get the care they needed, and then were pulled out of school. They're not able to participate in important educational opportunities, engaging with their community, and that also is a challenge for the entire family who starts to lose hope when they know that their children are not in school. And then also in Ecuador, a livelihoods program, a program focused on getting people to work. A number of the livelihoods coaches were seeing that refugees were having a number of trauma issues, domestic violence issues, and so they were able to reformulate their program because they were focused on outcomes to make sure that refugees had access to trauma care, to counseling, and to services for domestic abuse. And that then, once refugees got those services, they were able to rebuild their lives again. But it was that they were focused on an outcome and not just the number of trainings that refugees achieved, that they were able to really find some outcomes for refugees. So in conclusion, we see that we want to focus on what refugees want. Refugees want to be able to be self-reliant. They want to take care of their families. They want safety. And so we want to make sure that our programs are responsive to them. So our goal should be to help refugees achieve what they want. And unless we refocus our efforts to explicitly help them to achieve this, we will continue to fall short. Thank you.
Testing. Okay, thanks to all three of you. So I think we have 3 mics here, and I'm going to be posing a few questions. I also see that our system for questions from the audience is mics at the front of each aisle. So I encourage you all to think of questions for our panelists and come on up. I really think, Larry, actually, in a way, you articulated the theme for the next 2 speakers when you talked about capturing the passion of civil society, which was then reflected in what both Gabriella and Kelly had to say. And so I actually want to speak to all of you about variations on harnessing the passion of civil society, from global to local, from West Side community-based initiatives to the IRC. And so first, Larry, let me ask you a question at the macro level. If we failed to capture the passion of civil society to date, what can be done now to remedy that?
Well, I think, part of it is, well, there's so much. One, at the global level, it's really important for organizations like the World Health Organization to actually include integrally civil society in their governance, really listen to their voice. WHO does a very bad job at that because it's so worried about its member states and it's member state driven. But there are lots of governance models at UNAIDS and at Global Fund and Gavi that are much better. At the national level, you see around the world how governments, particularly authoritarian governments, really marginalize, even criminalize civil society, so empowering them. And so in our equity programs of actions, one of the first goals is to ensure that communities at the community level, the people who the policies will affect most, actually are deciding with policymakers about what those policies should be. And you can't just say, come, you actually need to empower them. You need to make it possible for that to happen, because a lot of these groups are very vulnerable. You mentioned, pregnant women, refugees. All of these are critically important to capture their spirit. But I think their spirit is there. We only need to open the door to it.
Gabriela, I want to ask you specifically about your experience working with local law enforcement. You provided a powerful example of a successful partnership on the west side of Chicago across perspectives, one might even say across disciplines, in working with the Chicago Police Department as in an opioids harm reduction-based approach. And yet, you went on to talk about a criminal justice-focused approach at the state level and indeed at the national level. How can we scale up a successful partnership between, let me put it this way, a successful public-private partnership from the local level to translate into an impactful policy change?
Partnership is so important. Partnership going from community stakeholders to people impacted, the things that we have to learn from individuals who are formerly incarcerated is such an untapped resource, and how they need to be brought in really driving that conversation. Partnership in finding that we share so many goals around human well-being and what works, and that's why evidence is so important. But it was actually, in that West Side partnership, it was actually the police who approached the researcher to initiate that project. As the people on the ground, as part of the people on the ground, they saw firsthand how so many individuals, right, years of putting people in cages wasn't working for anyone. It doesn't work for communities. The human cost is too high. And it also doesn't work for our society or for our legal system to have people who need health interventions and support and resources clogging up a legal system. So I think that there's a lot of mutual goals, and it takes us working together and figuring out what works to get there.
So Kelly, your description of the powerful civil society forces behind the Refugee Self-Reliance Initiative is really what made me think back to Larry's earlier mention. But of course, you're well aware that in terms of refugees, the host country does what the host country does. Not every country is a member of the UN Refugee Convention, and the new global compact related to refugees is, well, it's certainly voluntary to join, and it doesn't have the force of law. It is a non-binding agreement. So what do you do from your perspective as a civil society actor to maximize your leverage in the face of these sort of institutional barriers?
Good question. We're trying to identify as many avenues as possible to work with hosting governments. As you noted, host governments will do what host governments do. And so it's one of those areas where they need to see the incentive for themselves as to why it makes sense for them to engage with refugees and include refugees in terms of their self-reliance. And so I think there's obviously a very important role in terms of the research agenda around that, to be able to have data to back up what we're advocating for, to say why this makes sense, not just for refugees, but also for their own citizens, for their own government. But as we know, evidence only goes so far. And so there also has to be that political argument as to why it makes sense, and to highlight, especially when we think about people living in cities, we're thinking more and more about area-based approaches. If we look at neighborhoods and showing how, by supporting refugees, we can also support services that are available even for host community members as well. And so there's also the civil society engaging with donor governments who are in bilateral conversations all the time. I know more and more people are talking about the private sector. They're in conversations with the governments that we're not necessarily privy to. So to try to find as many touchstones as possible to engage with governments, including their own civil society. And that's one thing in working in Kenya. There's a dynamic civil society in Kenya and in a number of places. So engaging local civil society to put pressure on their own leaders to engage on some of these issues, and tying it and one of the things is not just tying it to this one vulnerable group of refugees, but tying it more generally to human rights in those countries, so that there's a bigger argument to be made.
So let me try to just reinforce that wonderful point. When I just came back from Geneva, what I was there for was to help draft the Global Action Plan on improving migrant health. And what we were told was that mention of the Global Compact was not permitted by some states. They wouldn't even allow it, or they wouldn't allow us to use right to health and human rights. And just think about what that means. WHO, which is the first specialized UN agency, is not even allowed to mention a United Nations compact that most of the world signed on to. And that gives you an idea of just what you were saying, Juliet, about how you've got these countries that really control things. And even the most basic things, like if we wanted to look at universal health coverage, job number one is to actually make sure that people on the move actually are part of the system. And they're not in so many places. And so there's so much more we can do. I think migrant health is just critically important to our future health.
And that really leads me to the second topic that I wanted to revisit with each of you. It's your saying that all roads lead to universal health coverage, or perhaps at least they should. Kelly gave examples of barriers of access to care. Gabriella powerfully pointed out the co-occurring conditions for pregnant women with substance use disorders. And so let's talk for a second about our own country and the practical realities here in the United States, where as a law professor teaching a course on health and human rights, when I talk about the healthcare system in the United States, there's no basis in law for using the word right or entitlement. Rather, I teach a class based around, of all things, insurance markets. So let's try to look at the glass as half full, but really, Larry, how can we put ourselves on the road towards universal health coverage?
In the United States, do you want me to be really honest or optimistic?
We can handle it.
The U.S. health system is a total mess, and I think it's and I think it's actually quite generous to even call it a system, because it isn't. And there's a lot out there about single payer or multiple payer system. I mean, I've lived, in the single-payer system in Canada. I've lived in the National Health Service system in the UK. I've lived in all-payer systems, say in Germany, and they're all, there are really a lot of paths to universal health coverage. In the United States, I mean, the Supreme Court has just had a totally deadly blow to the ACA. I know that it upheld its constitutionality, but it's at such a cost. So think about it. Now the individual mandate is gone, one stool. Right at the beginning, Medicaid expansion was gone. That was critically important to getting people into the tent.
Including to programs like those that Gabriella works on.
Right, and it's the poorer states that are the ones that have the least healthy populations that are the worst of it, and then the subsidies, which are under threat. So basically, all of President Obama's ways of trying to find a uniquely American solution to health care have been literally sabotaged. And now, of course, Juliet, as you know, there's this case winding its way through the courts about whether or not the tax bill, when it took away the tax penalty for the individual mandate, was like a house of cards and the whole ACA vanishes. Well, any law professor can tell you that that's ridiculous, because just like President Trump's wall, when Congress passed the tax bill, it specifically decided not to touch all the rest of the ACA. And so basically we've just got enormous executive overreach. And when we all go in global health and we visit other countries, there's one question that we're always asked, is this the new abnormal in the United States, or will we get back to center in 2020? And, I'm praying.
I'm going to turn to our audience for questions. Please feel free to come up to the microphones. I'm surprised the lines aren't queuing out the door already.
I'll get us started. My name is Natalie Best. I'm a surgery resident. I'm from Tennessee. I've gotten more interested in the human rights aspects of things. I've seen a couple of you in the surgery conversations as well. As far as being people in this room who understand the complexities of the issues at hand with regard to politics, and wanting to make a difference in these areas, how can we engage the society to decrease the fear-driven silos that are being created by our political system? I was kind of, before the candidates became the candidates in 2016, I had a couple of years before said, maybe Facebook will get rid of parties and we'll have like an actual person lead our country. And instead, here we have the results that we have. And so how can we who are interested in making the country and the world a better place and providing for the needs of these people encourage the populace to act on values that are not fear-driven?
Well, I can start just from the perspective of civil society again, is to just get involved. I think that is the most important thing you can do, is to get involved in your community, at your state level, and then also at the national level to engage your representatives, to let them know that is what you want. You want evidence-based healthcare, you want changes to the health system, you want a global perspective on healthcare and about human rights. There's probably many other specific things, but I think the most important thing to do is to use your voice.
And speaking on some things that I've seen in the past, just anti-stigma, anti-discrimination is so incredibly important. One of our homeless outreach workers in the Pathway program started an HIV anti-stigma campaign, and he had people across the state of Illinois just wearing bright red t-shirts saying HIV positive. Whether or not we were HIV positive, we wore them with pride, and we had many conversations across the state. And so the more that we can engage and the more that we can kind of just tear down that facade, we're all impacted by these health issues. We all love people who are impacted by these health issues. And the more that we can connect around that and inspire hope around that, I think that's essential to driving out fear.
It seems to me that sometimes there are countervailing forces in our society today, one advocating and successfully achieving acceptance, inclusion, broad-mindedness, and that countervailing force which seeks to sow divisiveness. I truly believe, and I think if people reflect on it, people know that everybody's more alike than they are different. And I was reminded by your question of John F. Kennedy's American University speech, in which he said, "We all inhabit this same small planet. We all breathe the same air. We all cherish our children's future, and we are all mortal." Seems to me that's more than enough to build a consensus around. Next question.
Stephen Marks, I have a question for Kelly, and I apologize in advance. Kelly, it's a loaded question. The Global Compact on Refugees refers to the need for member states to tackle root causes. There's a lot of human rights involved in those root causes. Have you put any thought into this, and whether that provision of the Global Compact on Refugees is going to advance in any way, shape, or form addressing the human rights issues that are part of the root causes that those who agreed, and we exclude, of course, the United States and Hungary, those who have agreed to advance the Global Compact, which means tackling root causes. What do you think of that?
Thanks for the very hard question. I think the Global Compact, while an imperfect document, does bring together a global community. I know the US and Hungary didn't sign on, but does bring the global community together around a conversation around refugee issues. And while I am sure it won't solve for all the root causes or all the human rights abuses, at least it provides a forum and a place to have further conversations around the important conversations. And so I think there's much more to be done in all parts of the Global Compact, and it's really just the starting place of those conversations as we see over the next several years. But at least it's a starting place after we've just tried to put our heads in the sand basically since 1967 about this issue. So it's moving the ball forward with a lot of work to be done still.
Thank you. Next question.
Thank you. I would like to start by wishing all the women here Happy Women's Day. My name is Imano Makasa. I'm from Lusaka, Zambia. I'm a medical doctor, and I had the opportunity to work at the United Nations in Geneva as a health attaché for my country for the 5 years from 2012 to 2017. So I have some comment about the functions and governance of WHO, as stated by the panelist. Yes, it's true that there's a mismatch between what the WHO is meant to do and how it's actually working and how it's governed. But what we all have to remember is that the United Nations, with all its specialized agencies, is a platform for member states. They created it and they work there. Of course, in the modern world, there is need to open up that space so that there is room for non-state actors to function. He does mention the functioning of the Joint Program on HIV/AIDS, or UNAIDS, and of course he also mentions the Global Fund. But if anybody cares to follow the actions or work of these specialized agencies, you realize that there is double standards between what countries say in one specialized agency and what they say in another. The problem is not so much that the organization can function, but the problem is the member states themselves. So you cannot be really punching the United Nations as an institution or as an organization or WHO. Rather, we should be monitoring and following what our governments are doing and what they are saying, because they are the ones. The US government will say something else at the UN and you block something else at UNAIDS or WHO. And it's not only the US government, it's all governments. That's what they are doing. So if we really want the governance and these organizations to work better for us as a people, we have to monitor and follow what our governments are saying in each one of these specialized agencies and call them out. That's what's going to change the governance. So I would like him to react to that, because I had personal experience. I worked as a health attaché in there for 5 years.
Thank you. That was really beautifully stated. I mean, the UN and UN specialized agencies, and let's just take WHO as an example, are member state driven. I've often thought that member states don't act like stakeholders invested in the success of the organization. If you look at WHO, for example, there are lots of things I would like the Secretariat to do differently in terms of engaging civil society and non-state actors. And I consider myself, among the world's greatest friends of WHO, and so friends tell hard truths. But another hard truth is that member states just simply don't support the agency. WHO gets about 1/3 to 1/4 of the funding of CDC, which is only one agency. It has a budget less than a large American hospital, maybe like Northwestern. And this is the worst part, it only controls about 1/4 of its own budget. Can you imagine any organization, public, private, national, local, international, that could thrive when 3/4 of its budget are beyond its control? And that's why you're exactly right, and it brings us full circle, that we've got to get our governments to be responsive and good citizens. The only way of doing that is through social mobilization, communities going to their governments, insisting that they do the right thing, and we don't do enough of that.
Truly coming full circle. Thank you for that response. Next question.
No? Hello? There we go. So my name is Ryan McCauley. I'm a physician at the University of Pennsylvania. I've also done several missions with MSF, Doctors Without Borders, in South Sudan as well as Egypt. And my question is directed to Kelly and Larry. Just if there is any conversation in your respective organizations or that you know of at the UN level about protecting migrants who are in detention centers, to set international standards for the time that they are spending there, to set health standards that prevent unneeded deaths, as we've seen in our own US detention centers on the southern border, and to also restore dignity. I have experience working in Egypt along the north coast during a time when the migration patterns through the Mediterranean were at epic levels. And we had migrants who were in detention centers in deplorable conditions for months and years. Children growing up in detention centers who never were able to go outside or had access to education, and 1 meal per day. So this is not being talked about, as I know, in big circles. And ICRC, the International Committee for the Red Cross, they have standards for prisons, but these detention centers fall outside standard definition and also fly under the radar for human rights abuses.
I don't think I'm well positioned to fully answer that question, but I do know that there are a number of organizations who are looking at that issue in terms of organizations that I have most experience with, the Women's Refugee Commission, I know is looking extensively at that here in the U.S. and also internationally. So I recommend that you look at their work, because I know that they're just about to put out a report from Italy that looks at a lot of the migration routes in North Africa. So I recommend that you look at that as an example of some of the advocacy work that people are trying to do more and more of, because like you said, it is flying under the radar with not significant advocacy at this point.
Yes, and I wanted to just pivot, if I may, because you said you had worked for MSF. Because migrant detention centers are a huge problem, and I wanted to kind of conclude with another huge problem we haven't talked about, which is actually the safety of health workers and the safety of first responders. Just a day or two ago, MSF held a press conference where it lamented 2 Ebola treatment centers being attacked in the Congo. We see polio workers attacked in Pakistan and Afghanistan. And in fact, you see health workers under threat around the world. And so it really is sad, if you think about it, that a person who's a healer or is going on a humanitarian mission, to have them fear for their own safety is chilling. I have a video, I can't show it now because we're too late, on my iPhone that Dr. Tedros sent me of health and humanitarian workers under attack in the DRC, pinned down for about 45 minutes in fear of their lives. You know, that really just should not happen, and there are ways that the United Nations and high-income countries should be able to help with that, and they just don't. In fact, quite the opposite. The United States has now withdrawn all of its personnel from the hot zone in the DRC, including the CDC, against the CDC's wishes, and USAID.
Well, thank you, Larry. And it's certainly true that the personal safety and security of healthcare workers, as well as, I might add, the same working conditions that we would expect for anyone in any sector, are essential to fully realizing the right to health. It brings me back to the keynote on corruption. My colleague and I were talking about causes and costs of corruption in the healthcare sector, and one of those causes is irregular, sometimes long periods of absence and low wages paid to public sector healthcare workers. Very simply put, that is an incentive to solicit bribes and petty corruption at the level of your local healthcare center. So, you know, flip it on its head. Don't necessarily single out the healthcare worker for engaging in a corrupt system. I don't see, as an anti-corruption advocate myself, I don't seek to excuse anyone who chooses to engage in that way, but back to the discussion of our national governments and local governments providing these wages to healthcare workers, it is incumbent on them to make them available so that the system is able to function. Thank you so much for your time. I hope you've enjoyed these diverse perspectives on a rights-based approach to global health. Please enjoy the lunch hour and welcome to Chicago.